to us, and we're just listeners. So at this juncture, I want to say thank you for you guys braving through the rain. The motorway has not been easy, isn't it? Yeah, so I can see the risk you take because I use it every day. And for those of us here, I'm grateful that the dullness of the weather this morning did not let you stay at home and be under the weather, especially Laurentia. So I'm grateful for the opportunity. Thank you.
Thank you very much, Director. Please let's do another for him. We'll get going with a few presentations. But before that, we all took protest yesterday. And last night, late last night, I got the result of screenshots. We were being 8 to 10. 8 over 10, 9 over 10, 10 over 10. The 10s were lots. 8. Very, very impressive. I'm not surprised there were no questions because you're all intelligent. So let's keep it up. But that doesn't mean that you should ask questions. But it was very impressive. Let's keep it up and make day 2 even better. Thank you very much.
Hello.
Hello. Hello. Can we please move forward so that we make it easier for... I know I'm raising the mic. I wish I wouldn't, but if you do me a favor by moving forward, let's fill up the front rows. Thank you. I can see some people making an attempt to move forward. Thank you so much for your kind consideration. Yes, they are coming. Yes, those at the back. I can see you're moving. You can be nice.
I'm very low.
Yes, please surround him. Keep him warm.
I'm very low.
And the weather is cold, you see.
Very cold.
Yes. Auntie, please come and give it to me. I'm asking you a question, but you just come. Please. It would be nice to have you in front. You can sit anywhere, you don't necessarily have to sit beside you. You would think about it. We'll be waiting. Alright, so hello everyone. Good morning.
Good morning.
How are we all doing?
We are good.
Okay, so we're going to talk about adherence treatment guidelines and protocols. I would like to know the header of honorable participants we have here to make it easy for me to maneuver myself around the slide. So, pharmacy staff, are we here? Do you have any ward nurses? Okay, and then QI. She's the person from ITC, focal person. Here. And who else?
Doctors.
Yes, doctors, prescribers, PAs and doctors. Wonderful. Oh, only one? Oh, they'll join us soon. Doctors. Wonderful, wonderful. Okay, so we can start. Yes, lab. Lab. Please forgive us. Give me a wave. Thank you. So we have the full complement of the house. We're going to talk about adherence to treatment guidelines and protocols. Okay, so why are we here? Why are we here? Anyone? Quickly. This session has to be active because the weather is right. But we won't allow them. Yes, why are we here?
So we are here to understand the nature of the Drug and Therapeutics Committee that one at the hospital and how that can be used to champion our antimicrobial stewardship activities to strengthen it at the hospital. Thank you.
Thank you very much. So I can hear antimicrobial stewardship, more like the watchmen or the guardians or the gatekeepers of antimicrobial use in the healthcare setting. Why are we worried about antimicrobial resistance? Why is it such a big deal? Anyone?
Resistance, yesterday we learned that it's standard its own problem, and we want to safeguard the few antibiotics that we have, so that we don't have to spend a lot of money, we don't have to push patients getting resistant and having side effects from the few antibiotics that we have available.
Excellent. You said it all. So, how much is it Meronep? Which antibiotic is the most expensive we have on the market now? Anyone? Okay, so linear pricing is very expensive antibiotics.
One of them is Ceftaroline, which is a fifth generation cephalosporin. One vial is about 800 or 800 studies. Yes.
That's 8 million gold currency. And what's the like 5-7 days or 40? For regular use.
Response is 5 to 7.
So you see the problem antimicrobial resistance is giving us. And you mentioned 5th generation. So it started from 1st, 2nd, 3rd. And I'm sure that the generations are going up and up. And we might end up at 10. We hope not.
Unfortunately, we don't even have that opportunity to end up at 10 because the big farmers are not even producing or investing more on newer versions of the antimicrobials. And so the more we advance to the 4s and 5s, the more we are getting towards a point where we will not be able to treat the infections that are resistant because we don't have new antibiotics that are susceptible.
Thank you. The more reason why we need antimicrobial stewardship so that we can combat this trend of having the microbes getting stronger and then antimicrobials not working on them. And this comes at a cost. Comes at the cost of finances, quality cost, and then life. Is it true? Okay. So we are saying that hospitals are critical components of the global AMR problem. Of course, naturally, in a healthcare setting, we think that, or we can see that, if people are not sick, if they don't have germs that are bothering them, they will never come to the hospital. So in the hospital, if you compare the hospital to another setting, we have a lot of germs, a lot of microbes, disease-causing microbes, concentrated in the hospital setting. And that is where the AMR problem focuses. And then there are 6 institutional interventions that drive rational antimicrobial use. By defining treatment and clinical practice guidelines or rules, and then the role of treatment guidelines in the optimization of the antimicrobials. Examples of treatment guideline instruments used globally and in Ghana, that's our local one. And then the core features that makes the guideline fit for purpose. So we are saying that hospital concentrates that accelerates antimicrobial resistance. Of course, that's where a high concentration of the germs are. If we compare it to other settings, we would see that because people are sick and they have germs, they come to the hospital. And then the activities or the practices we carry out at the hospital setting enhances the antimicrobial resistance if we don't do it properly. And we are saying that if we don't have institutional governance, then hospitals function as amplifiers where they magnify or they increase or they enhance antimicrobial resistance. And then we say what? Exporting them to the community. So it doesn't rest at the hospital level. The community members also end up contracting antimicrobial resistance microbes from us. And they will always come to us. They will always come to the health facility. So it's more like a cycle. All right. So highest density of, we already mentioned, and then the resistant organisms are more at the hospitals, and then they are gateway between the community and then the tertiary or high level facilities. Okay. Now, selective pressure from prescribing. They are saying that it's concentrated and often empirical broad spectrum antibiotics use. Selects for resistant strains faster than in community setting. So, an example would be like if in the hospital or in the healthcare facility where we are treating these disease conditions, we give certain antimicrobials. They go and then they destroy the purpose for which, or the organisms for which we are giving them. However, there might be a few, maybe 100 microbes, and then about 3 or 4 antimicrobial resistant germs also there. If we do indiscriminate prescription and administration of these antimicrobials, we might end up killing all the ones we are getting anyway, killing other ones that might be helpful, and then we end up helping the 3 or 2 that were there to multiply, meaning there are no other organisms there to hinder them from multiplying. And these patients or these clients might end up having an increase in antimicrobial resistance strains. Please, are you getting the picture? All right. So another one is we are saying that the resistance strains faster in the community setting. Might go to the community, and then cross transmission pathways. We are saying that in the healthcare setting or the hospital, these are some of the things that amplify antimicrobial resistance: shared staff, equipment, close patient proximity. In the review or in IPC, we are saying that there should be, especially in isolation situations, we are saying there should be a certain length of or a certain distance between beds of the patients we are treating. This is an example. We are saying that close proximity, or if you have an example of overcrowded ward. The beds are so close because we don't have enough space, no bed. Sometimes we end up placing our mattresses on the floor because we can't send them out. So overcrowding forces the microbes to be exchanged between the sick people we are taking care of. Also, we are saying patients, okay, then centers, and then resistant organisms spread between wards and patients. High-risk patient population, an example would be in the ICU, neonatal, surgical patients, and then immunocompromised HIV is an example. Oncology is also immunocompromised because in cancers they are undergoing treatment and the medication sometimes or most of it suppresses their immune system. And then we are saying they are exposed to invasive devices, raising infection and resistant risk. Okay. Any question at this point? Yes, please.
I'm concerned about the cross infection.
Yes.
Necessarily, when we find ourselves where we are not supposed to tend the patients, even if the place is full, and we still have to nurse them or manage them to the floor. And we are coming for the 12th. What are we doing? Are you talking on our behalf?
Okay, so that is the reason why we are here. DTC is supposed to come to a program. So you make a case for why we cannot nurse our patients on the floor. In fact, this is a very weak three-legged table we are shaking. You know, the table is not stable at all, but this is at the administrative level. But we can make an input. When we are done with this training, we realize that there's so much power in DTC. There's so much power. There's so much power in the sense that we can make a case with empirical data. Please, are we? So this your table is very weak, but we'll get there. Thank you very much. All right. So what we have here is global and national this data, and we are saying that 1.2 million directly attributable to bacterial AMR globally every year. What's the world population as it stands right now? World population is very high. That's 7 billion. Hey, so And then we are saying that in future we are anticipating that, or we are estimating that annually, deaths by AMR around 2050 will be around 10 million. And the figure goes to national budget share of asset category antibiotics in total consumption. So when we look at our national budget, 60%, more than half of it, is looking at national target share for asset category of antibiotics. We'll get to what it means, the asset category of antibiotics. Okay. Now, we are saying institutional interventions against AMR. Our aim is to put measures in place to reduce the incidence of antimicrobial resistance. The first thing is infection prevention and control. Who can tell me why it is very important before we go to the rest? Anyone? Good morning. I can see you in the office. I've seen you. Thank you so much. Why IPC is important?
IPC is a measure used to generally prevent diseases. I'm not a clinician, but this is a little I know.
That's an excellent answer. So we are saying that how did we get to antimicrobial resistance? How did we get there? Yes, how did we get there? How did we get to antimicrobial resistance? Any idea?
It's infection.
Spread of.
It's spread of infection.
So we are saying that IPC is more like we don't even want antimicrobial resistance to happen. So this is the first line. If we prevent movement of microbes between sick people or transfer of germs or disease-causing microorganisms from person to person, it will help to reduce the need to use antibiotics or antimicrobial drugs, thereby reducing the need to go to the fifth generation. So we are saying that infection prevention is one of the means of reducing the need to administer antimicrobials. Not because the person needs it and don't want to give advice, because it is an infection that the person acquires after we have taken the person and promised that we'll take care of the problem they came with. And then before you know, they'll have another infection from us. Alright. Then Hospital Therapeutic Committee, that's the DTC. We have the institutional formularies. These are formularies made to guide in diagnosing and treatment. And then we have the lab. Without the lab, we can't do much with antimicrobial resistance work because they need to give us empirical data, lab data, enough data to give us a reason why we should take action A, B, or C. And then stewardship. When the lab gives us the information, we said we'll do A, B, and C. Who is going to guard A, B, and C we have decided to carry out? Is the stewardship. And then clinical practice, and then treatment guidelines. Okay. Any question at this point? So under infection prevention and control, it is said that hand hygiene, that is washing your hand with soap under running water, or the use of alcohol-based hand rub, can give you about 80% reduction in transfer or transmission of infections in a healthcare setting. It is cheap, it's the cheapest method, and it's the easiest to do. Even in the desert, you can wash your hands. Anywhere, if you have water and soap or you have alcohol hand rub, you can clean your hands and make it safe before you take care of the patients. And on the hand hygiene, we have 5 moments. With the 5 moments, I'm going to pass the mic around so that yes, let's start from here. 5 moments, give us one.
Before any procedure and after that.
Before any procedure, anyone? Anyone? My favorite part is after exposure to anyone. Do you agree? How many of us don't like that one? Show by hand. As hand hygiene after exposure to body fluids. That's my favorite part. You know why? Because on your body, somebody's like, oh, you won't wash your hands. Or, so I've said that one. No one should say it. Yes. No, it's mine.
Yes, very hard.
So, before
Thank you very much. She has said in the hospital and then outside the hospital. Yes. Somebody should give us the hospital one. Yes. 5 moments of hand hygiene. Instances at which you will need to clean your hands. She said your own name. Okay, so we mentioned before and after any procedure, touching the patient's environment, exposure to body fluids, and other secretions. Which one again? Yes. We've talked about the environment, we've talked about the before any procedure on the patient, you should. Okay. So we are saying that the 5 moments of hand hygiene does not allow you to guess when to decide to clean your hands. It gives you all the instances, especially if you are close to a sick person. It gives you all the required instances at which, by all means, use the alcohol hand glove or you wash your hand. Okay. Any question? Then isolation precautions. What are the isolation precautions? There are 3. I'll mention one. Airborne. Anyone? Anyone can remember the other 2? Okay. And we are saying that these precautions prevent transmission of germs or microorganisms from the staff to the patient, the patient to the staff, especially the patient to the staff, and then between patients. Under isolation, we separate or we nurse the infected person away from the general ward. And then what else? We talk about PPEs, we talk about hand hygiene, we talk about what the mask and the respirators and everything. Okay. And then surveillance of HAIs. So if we suspect or we can tell, we have a certain idea that there's a high risk of cervical site infection in our facilities. How would we know? How can we tell? We can't guess so. That's last week, at theater, they carried out 21 surgeries, CS, and 2 of them, the ladies came back post-op review with, how do you say it? With the wounds infected, leaking, and very wet. Are we going to say surgical site infection? We have a criteria for, and the period is from 1 to 30 days. But that is after we have given the patients all the education they need, so they don't go and mess it up. So if we keep records, we hear 2 out of the 21. What are we going to do? It sets the alarm to start doing surveillance, because we had to hear word 1 year, like, oh, I met her in town, she had this, she complained, this and that. But who is going to find out? How are we going to find out if there's a trend? Maybe it's just 2 here, but there are more than 2. So we need to track and find out, get information, collect data. Please, are we getting it? So we need to actively monitor. Very good. So we need to monitor and then get the information to make informed decisions and then find out what remedies we can apply to it. Environmental cleaning. I have a question. So if you have the privilege of getting free 5-day admission, if you're not feeling well, at IMA. Who knows IMA? Anyone? IMA. Hey, fantastic. Somebody don't even want to go, but it's expensive, you see. But if somebody is paying your bills and you have the opportunity to be admitted there, and then you have another big opportunity to be admitted in your own facility, I'm not sure, are you all from here? Please, I need permission to carry on. Can I? Thank you. So you have the opportunity to be admitted here. There's no VIP because you don't have space, so you have to join the regular crowd on the ward. Please show me that. Show me, I'll go to IMA. Who else will go to IMA? Anyone? You go to IMA. You will come here. Oh, show me, I will. Loyalty is good, but you know, why? Why would we go to IMA? Madam, are you going to IMA?
Because comparing IMA and here, that place is spacious. There's a VIP treatment and all.
What about the environment?
The environment is very clean. Yes, it's always clean. The environment is on top, like that. Even when you enter the gate, it's clean. The surfaces are all clean. So we can imagine or guess that, hey, that there are no germs here. Or, yeah, but it's a misconception. The point is that cleaning environments, if we do proper cleaning with the right detergents and chemicals, reduce the amount of germs we have in the environment. Clean environments prevent us from touching and spreading the germs all over the place because we have cleaned them. We have reduced the amount of germs on the surfaces, especially with contact. Clean environment means that all the surfaces that we touch, the door jump, I actually wanted to wipe it, but I forgot. The door handle, the door on the wall, and even at the administrator's door, you can swap and see. You know why? Because everybody goes there. All the office people's doors, pharmacy door, pharmacy counter, where are the lab people? Lab counter, it's my favorite spot. I'm Fatumo. Hey, should I do something about them so you see, records, we don't have records people here. They are counter. Madam, spell your name. What? Before you know, there's a lot of space. At the end of the day, it feels moist and there's still it's the surface. How often do we clean those surfaces? Madam, give me your card. You collect the insurance card. Touch surfaces. Please, are you getting the point? On the wall, it's not too clean. Sometimes it's so depressing. Yes, environmental clean because the germs, we sprinkle them, the patients sprinkle them, our activities spread them all over the place in high concentrations. So environmental cleaning is very important so that we reduce the amount we have in the environment, and then in one way or the other, it helps. Please, any question at this point? Okay, so now we are there. Any question? I know we know IPC already, so we'll just go through. Now, DTC committees. The committee is the institutional governance body responsible for rational, safe, and cost-effective medicine use, and the primary vehicle of institutional antimicrobial stewardship. What does the DTC do? Can we all see? Can we see? So they develop and update facility antimicrobial formulary. They commission quarterly antimicrobial use surveillance reports. They review antimicrobial related adverse drug reactions. They approve empirical treatment protocols from local antibiogram data. So antibiogram is just, every facility has its unique kind of special germs you will find depending on the kind of clients you see. So when the lab people do their things, you find that there's this particular microorganism persistent in this facility. If you go to the Mapami clinic, it might be different. So our special or our own unique germs that we find frequently in our hospital space will be the information we get from our biogram, kind of our special data relating to the specific facility where we are working. Please, are we getting me? All right. And then it will oversee facility AMS teams, work plans, and targets. We will have an action plan and then our work plan. That's if you look at the DTC functions. And then we coordinate prescriber training and CPD on AMS principles. So DTC has a lot of things to do. It has to do capacity building. It has to oversee surveillance, disseminate information from the surveillance. It has to decide with the national formulary on what kind of treatments or drugs to give to the various disease conditions. Okay. So our institutional formularies are the curated or specially made AWA. So it's aware. Can you see? Please, can you all see? AWARE. So we have aware. That is a line list of approved medicines that concentrates prescribing and on first choice lower resistance risk agents. So the A is access. The access just means that the normal everyday, not to high-level treatments, which we are encouraging because we don't want to graduate our clients too quickly on the spectrum to our fifth generation. Please, are we getting it? So the A is just our local level antibiotics that is safe to use and have a low antimicrobial resistance characteristics. Then the W will be the ones we are watching. It means these ones they are suspects. The W is watch. We are watching and we can see that these drugs, if we are not careful with the way they are prescribed and we don't do the right thing, they might graduate to the antimicrobial resistance class. So we are watching them. And then the R is those ones, they have a high tendency to lead to antimicrobial resistance, but we are forced to use them because of the condition of the. Please, are we getting it? And then the E is a no-go area. The E there, after the R, there are treatments or drugs that we do not approve to be used because they are actually, the microbes are actually resistant to them. So the formularies are based on this. So moving from the low level gradually, if there's a need, you go to the next level. And then if we see that it's highly resistant, we move to the next level. And then at the last level, we don't go there at all. So our hope is that with the decision formularies, we're able to stay within the A, the amoxicillin and those metronidazole, they are now we are really graduated, they are no longer working most of the time. But we want to stay around those areas. Please, are we here? Alright, so we are saying that is to maximize access, watch agents, and then define indications, limits, reserve agents, and then to senior approved. Okay, so I've already explained it. And we are saying therapeutic substitutions or delisting. Sometimes we have a certain, the formulary says that there's this level you can go to. But we realize that with our service and our lab results and then DTC action, we're realizing that there are some drugs we need to remove them from our formulary. We need to stop buying them because of the results we are getting. And then sometimes we need to substitute them or might have to combine, or sometimes we realize that this one is not really working for this group of people. So let's find an alternative. And then if it's not really working at all, it's giving us too many problems, then we'll just take them off the list of drugs we would be needing. Microbiology laboratory. Yesterday we had a presentation on the labs, and what we got from there was that we have to do culture sensitivity before we prescribe. Yes, is that what's happening at the consulting rooms? After the health workers, we don't do lab. Hey, you know the symptoms. Oh yeah, you swallow and then you are fine. So your neighbors think that you never fall sick. You do. It's just that you are doing your own thing at home. Yes, but with the labs, do we always do culture? Do we do culture sensitivity? Yeah, prescriber.
Are we able to?
Yes. At pediatric emergency, when in a child comes with temperature, the sickle cell patient, the first thing we do, take the culture before. That is our practice.
That is what we are all looking for. Because if we have a specific information from the lab, it makes it easier for us to know exactly what to prescribe. So we don't do, most of the time we do blind, pardon me, prescribers, but most of the time from experience we see that there's so much pressure. The patient is telling you, Minister, this one insurance won't pay for. So we are like, okay, then let's just try to help the patient, and then we end up not doing our culture, so we know exactly the kind of antibiotics to give. And then I've already mentioned the antibiogram. There are unique information regarding the specific gems we have in a specific location as in our general hospital. And it also helps from the lab, it helps us to determine how to prescribe our antimicrobial agents. And then any outbreak detection, so that here, if on the ward, surgical ward, you realize that for the past 6 months, every client who comes after surgery ends up with this kind of infection. Or maybe on the general ward, the genitourinary ward, realize that there's a lot of urinary tract infection, and we have picked one particular microbe or germ that is really causing it. We could have consent for outbreak detection. Maybe there's an outbreak. Where is it coming from? So this will help us. The lab will help us. Once in a while, they come for their routine every month, swab or take samples, and then just for the information we need. Okay. And then turnaround time standards. So it's results. It implies results enable escalation from broad to. Okay, so this one is just trying to tell us that the turnaround time standards, it helps us to determine the levels or the grades or the generations depending on the kind of lab results we get. Some drugs might not be working, so it helps us to. And then sometimes we have stopped a lot of these particular drugs, but we realize that it's not really working. So we take decisions around those issues. Any questions? Now we are at antimicrobial stewardship. We are the stewards, DTC. We are the stewards, or we are the gatekeepers, or we are the watchmen. And we are saying that it's a coordinated program ensuring that every antimicrobial decision is the right drug, the right dose, the right route, and the right duration for the right patient. And the first point is prospective audits and feedback. The antimicrobial stewardship just helps us to review active prescriptions and provide real-time, non-punitive feedback to prescribers. Do we do that at DTC? Have there been instances where we have had to contact one or two prescribers and then share consent? Anyone wants to share? DTC? Or any other person who wants to share? Pharmacy? The pharmacy, yes. Anyone who wants to share? Yes, please.
Yes, we do that a lot. We collaborate. If there's any, if you have any issue with the prescription, we call the prescribers and then we talk with them. And we arrive at a decision. We do that a lot.
Yes, I wanted to emphasize on the a lot because it's teamwork. So we do that. It's like team. It's something that we do. It's nothing to it.
Perfect. Usually a peaceful one. I'll come back to you.
So Dr. here was trying to draw attention. I worry him a lot when it comes to some of the issues with reconciling. So sometimes you see a trend, especially with antimicrobials, post-CS, and then we try to call to reconcile, arrive at a decision to ensure our antimicrobial consumption is well within our time. Yes, Dr. Moise.
When you finish, you tell me about whether it was peaceful or it was not peaceful. Because there's a word punitive there we would want to discuss.
So thank you. So Jenny is right. It's something that she's been. I think for the past 2-3 years, she's always on us. And it's very peaceful. She comes down and she's stationed at our department, so it makes it easier for us to work together. Thank you.
So it means you have set up your tents at their department and you are constantly checking them. That's wonderful. Let's clap for him. Okay, so I'm asking about the punitive because sometimes we've had experiences where there's this concern for the use of antibiotics. And the prescriber is telling you, since 1666, when I was a student prescriber, this is what we have been using. Even my grandmother, the same disease condition. So why do you have a problem with me using this one? Sometimes anecdotal experiences naturally would push people to stick to a certain mode or style of treatment. So the aim is, and I'm sure she's doing it nicely, that's why you are saying something nice like that. Thank you very much. So the aim of feedback is not to find fault. Our target is to make sure that this patient doesn't develop antimicrobial resistance, the microbes you are treating the patient. So it's just more like a discussion. And then we all come together and agree that, oh, this these things are the new things that have come. New formats, new formulas, new policies have come, and this is the way to go. And it's all aimed at ensuring that our patients are getting quality care and they are safe. Please, are we here? All right. So, prior authorization. So we watch and reserve antimicrobials. Okay, so the watch and reserve antimicrobial requires sign-off from designated AMS lead or DTC before dispensing. You remember I mentioned that the access, the A is just our regular everyday. We're not afraid to prescribe or dispense to our patients. The watch ones are those which have high propensity to lead to antimicrobial resistance. And then the reserve ones are the treatments that actually we have evidence that there's antimicrobial resistance. So these two categories, we don't just allow the parents to prescribe them until the antimicrobial stewardship team, any of the members that's qualified, will confer and then decide that this is what we are going to do. So they go ahead and then prescribe those antimicrobials. So that you don't just, and then you have to sign off. There must evidence showing that for this and this treatment, this class of antimicrobials were dispensed. And then we can even track it to see whether it is working. Okay. And then prescriber education, we talk about continuous training and then we provide up-to-date information on new trends that are coming. So the use of clinical practice and then treatment guidelines. We have our treatment guidelines here from the Ghana Health Service. They are standardized evidence-based guidelines that translates every other intervention's principles into consistent day-to-day prescriber decisions. So the guidelines are just like our textbooks where we follow. The information in the guideline is scientifically proven that it works. And if we follow it, it will help our patients. So they are just like a textbook or a guide to help us make our prescribing decisions. And they are standardized everywhere across the country, especially the Ghanaian ones. It applies everywhere. Okay. And at the various levels, from the lower level facilities to the very high level facilities. And we are saying it's a bridge to the rest of today's session. Now, okay, let's move on. Okay, so DTC, how connected are we to IPC? Do you have an IPC focal person on your team? Yes. Okay. And then we have the QI person also here. Alright. So we are saying that IPC, DTC, formulary, lab, antimicrobial stewardship, and guidelines are one set. They don't perform in isolation. So that the DTC is here, the lab is there, doing their own thing. Our documents are also somewhere, we're not referring to them. And then the antimicrobial stewardship tool is, we're not really seeing their actions, we're not seeing their performances because it is like everyone is minded his own corner. Please, are we getting it? In order to fight antimicrobial resistance, all these sections are supposed to work together as one team. Because without the lab, we cannot have a surveillance to track and then identify the microbes we are working against. And then without IPC, we cannot even prevent the infections so that we don't have too much work to do for the antimicrobial stewardship team. And then the DTC too, without all these people, the DTC cannot function. But they are the reason why we have a DTC committee. Alright. And without the guidelines, nothing will guide us to how to do our work. So what are practice guidelines? They translate best available evidence into clear, actionable clinical recommendations. They standardize, diagnose, investigate, and then treatment decisions are carried out across all prescribers. So all the prescribers will follow the treatment or clinical guidelines. The clinical guidelines translate real-time information and then they tell us what to do. They specify, I already mentioned the aware, they specify first, second, and then alternative line antimicrobial choices. By indication means the specific infection we are treating, so that we don't go blind. Okay. And then it also applies every level of care. I already mentioned that at every level, from the smallest to the highest, from the chief zone to the teaching hospitals. The chief zones, sometimes they feel so isolated. Meanwhile, the kind of magic they are doing there, prescribing all kinds of medication. Sometimes they have just one prescriber, and then maybe 2 midwives. But they are taking care of clients like their polyclinic or even higher. And they admit. So the guidelines and practice guidelines all apply to them. So we distribute them and then we train everyone to follow. Alright. So we have the contents of our guideline documents, and we have the diagnostic criteria. So these are the signs, symptoms, and tests defining the condition of the patient. It also talks about the first line therapy, the preferred agent, the dose, the route, and then the duration. Then we go to alternatives. If our first line therapy doesn't work, it tells you the subsequent or the alternative routes of administration, which drugs you can give next if your first line doesn't work. And then we talk about special populations where we adjust the treatment or the drugs or the antimicrobials per their impairments, pregnancy, or even for pediatrics. So we talk about the age range, we talk about the comorbidities, we talk about physiological problems or issues which we need to consider before we decide to give antimicrobials. For some people, you can't give certain drugs because they have kidney impairment. For children, there are special doses we can use, and for some children, there are some treatments you cannot, antimicrobials you cannot prescribe. So these are the special populations. For pregnant women, we know we can't give the general ones, regular ones we give to our non-pregnant population. And then it also contains monitoring parameters where we track during treatment and when to reassess. On a normal day, most of the time, our treatments, we give the treatment to the patients, they leave us, and that's the end of it. Do we get feedback? Do they come back? Ideally, they are supposed to come back for some conditions for which we are giving certain antimicrobials. They are supposed to come back for our lab works, or isn't it? So that we can assess, review. But don't come. He's calculating his chlorine, but he's feeling okay. He didn't even finish taking all the medication, but he's feeling fine. He has drunk this water small on top of it. So, case closed, isn't it? So they will even come. But in some jurisdictions, advanced countries, they track and they follow. And this all helps in combating antimicrobial resistance. But in our setting, it's difficult, but DTC can make it possible. That's why we are here. Do you agree? Alright. So, we also talk about referral criteria. Sometimes you have given the range within which your facility is allowed to give, but it's not working, or you're not seeing any progress. So you move it or refer to. Sometimes you keep the patient there, but you have to refer to certain high level levels so that you can have approval to administer the next line of treatment. So this is what the guidelines contain. I'm sure we have seen them. We've seen them. After we've seen the guidelines. Yes, okay. And then the antimicrobial optimization. The right choice, right dose and duration, reduced variation, and then resistance containment. I would like to talk about the reduced variation. It's saying that we narrow appropriate prescriber to prescriber variations, lowering both overuse and undertreatment. Sometimes the prescription is high. Say, madam, this is your medicine. Let me give you a higher dose. Can you buy this medicine? It's expensive, but it will help you. So prescriber A is giving a very high for the same condition. All things being equal, giving a very high dose. But it's not very good at very strong, generic, expensive treatment. And then in another setting, prescriber B also is like, so they don't have money, they don't give him. So they end up underdosing. Because you can afford the 3-day, when it's supposed to be like 7 or 14 days, but you can afford it. So, or sometimes they use make those decisions. And then also if there's a resistance, if we determine or we detect that from our surveillance data collection, we see that there's resistance, we can put measures in place to contain it, resistance to the antimicrobials. Now, from empirical guesswork to precision therapy, first, before, if we are not, are we doing paperless? Or are still doing folder? So we have graduated. We used to carry folder. Some of this folder is like 25 years levels ahead. But we have stopped. We are doing paperless. Yes, in medicine and in combating antimicrobial resistance, we are not doing guesswork anymore. We are precise, followed by data, empirical data, and then thoroughly investigated. And we are sure that this information is true. It's a fact anyways. So we're no longer doing the guesswork. And we're saying that now it has to do with indication specific selection. So the guidelines are telling us that we map clinical syndromes directly to the aware we mentioned earlier, the preferred agents, remove ambiguity at the point of prescribing. So when we are treating these patients, we are sure we look at the guideline, we open, we look at it, we go through the steps. There's no guesswork, and then we are saying that we are going to follow the access, watch, and then our regime, and then it's going to inform us as to specify what we should do. And then we are saying that it gives standardized dosing regimen. So mostly it is weight. I'm sure we all use the weight because it is standard, and there's evidence to prove that that's how the medicine works with the weight. So we use weight-based, and then we know how to prescribe our medications. Okay, and then we avoid overdosing and underdosing. And then it gives you the prescribed treatment duration. It defines how long you should give antibiotic A and B. It also reduces variation, and then it reduces the incidence of resistance because we are following the procedures as stipulated in our guidelines. And it goes to anyone who prescribes antibiotics follows those procedures in the guidelines and is on top of the game. So we don't do any guesswork, and then we don't make mistakes. It de-escalates. Okay, so step down from. It says that the guideline is going to step down from broad spectrum empirical therapy once the culture results return. So like I was saying, we prescribe antibiotics or antimicrobials, and we don't get feedback to see whether the desired effects we are getting is actually there. Most of the time, the patients feel better, is able to get out of that 6 days, and then we assume that the medication has worked. But this guidelines tells us that we need to follow up and then find, if it doesn't work, we find other methods. Okay. Then it serves as a gatekeeper. All right, self-explanatory. So these are the examples of the treatment guideline. We have the WHO aware antibiotic book. We have the essential medicines list. We have the essential medicines list, and then we have the standard treatment guidelines in the prescribers corner in our consulting rooms, and then we have the essential medicines list. Okay. So the WHO antibiotic books is just organized in clinical syndrome for rapid bedside reference. It explicitly links recommendation to the aware category. The framework or the foundation upon which we are administering our antimicrobials is on the aware policy because it helps and it reduces the incidence of antimicrobial resistance. Please, do you have digital standard treatment? Not this one, but are they all book form, physical books? Or we have digital ones too? Okay. Alright, the WHO one is digital. And it's available digitally, accessible to every prescriber. And it complements but does not replace national standard treatment guidelines. The Ghanaian one is picked, what we have in the Ghanaian standard treatment guideline is picked from the WHO guideline and tailored to Ghanaian needs. So every country picks the baseline is the WHO one, and then you tailor it to suit your national need. Okay. Any question at this point?
Yes.
Please.
I think this one is more of a problem that we see in practice when you were talking about the guideline and the fact that the WHO guideline will still not override the national guideline. So we've had instances where we, through the DTC, we wanted to look at the guideline compliance of some of the priority infectious diseases related like community-acquired pneumonia, surgical site infections. And then when we use the standard treatment guidelines as a base, we had a lot of challenges, especially coming from prescribers that they have dated guidelines with data that is appraised, level of evidence on point. And so they don't understand why we are still using STG, which is our data, as the basis, just because it's the national guideline and it cannot be override. So, I mean, sometimes these are some of the challenges we have on the ground.
Thank you. Any other concern in the same direction? So I think, if I understand you clearly, they think, so they don't really have much regard anymore for, is that what it is?
So it's not
Or
like,
they-
let me even correct it, it's not like they think. I think, in fact, all of us, we think. Because we also appreciate the perspective they come from. When we are exposed to other international guidelines, and there's new evidence that suggests otherwise. So let me use ONG for example. Dr. Mo is on here. So ONG, we use oxytocin and all of that, and now on the grounds, we are not getting the effects that we want to see. And so we did a survey and we saw over 90% of stretch to carpetocin, and they say it is working. It is working. On the grounds, I use oxytocin and I sleep in peace because I'm not expecting a PPH. And you see the international guidelines, they've updated that in lower to middle income countries, you can use oxytocin or carpetocin. For lower to middle income countries, then I see also see some of these things with high level appraised evidence to support.
So I think that is the reason why the DTC is in place. You can also adapt. Until the STG is updated, you have to adapt. I mean, adopt some of these new evidences for your guidelines.
Thank you very much. So, but when you adapt, please track it. It helps to make a case for subsequent presentation. Before you know, they want to update and they want to call people who have used the current ones, and then we will make a case with the evidence that's added after you have used the new ones that are. Thank you. So we're saying it underpins the development of national essential medicines, including antibiotics on the list, are tagged with their aware category, and then they are used as benchmark for procurement and formulary alignment. Hey, procurement, when we need medicine, they always, this is a benchmark. Do we get the cooperation from them?
Hello, I would like to know if the evidence you have gathered is documented.
Sorry, by evidence, do you mean so in the case I gave, it was WHO updated treatment or protocol for preventing PPH, postpartum hemorrhage. Yes, and then in our system, the first line is oxytocin. But then now the WHO, in fact, previously the WHO also said oxytocin, but now they are saying oxytocin is first line in other countries, like in the other countries, but in lower to middle income countries, carpetocin and oxytocin person is first line. So it's evidence that has been appraised with evidence level or strength of evidence at A. And so I didn't get your question by if we've documented the evidence.
From your narrative, you have done something in 90%. If I can.
Oh, okay.
I would like to that 90%. Get any document on the 90% that you are seeing.
Yes, please. So we actually just did a survey of the total number of people who had the cesarean section, and then out of that, the total number who received the newer drug, which is the cardiotosin. So yes, that is documented. We even had a presentation of that at our DTC.
That's wonderful. So you are keeping the data. Maybe one day we'll come and with our bosses. And then you provide that information and it might contribute to something. Alright, so the bench we talked about. Yes, procurement is also a guide to procurement. Please introduce yourself.
My name is Rosina. With the drugs that you're talking about, it comes with time. You have it with time. Due to the delays in the supply chain. So that's why the drugs don't come. But you have the drugs on time. Thank you.
And do we get the specific, especially with antimicrobials, the antibiotics, do we get the specific mass request?
With the specific, it depends on the specifics on the menu. And sometimes when they bring certificates from the various regions, that's what we use to procure. Without it, I don't sit in my office there and procure because I want to procure. I procure the based on specifications. Thank you.
So we have understood from procurement that what resources they have available is what they use to provide us with our product. Thank you. So we have essential medicines list at the pharmacy. So we are set. Alright. Now, features of a sound treatment guideline. So an expert committee sits and then they develop the guideline. And then it is not done in vacuum. We have specific information, data, and then everything is put together. And there's proof that if you use A, B, C, and this, as we have stipulated in the guideline, it works. And then it's cost effective. When we are making or coming up with our guidelines, we also look at cost, considering the different socioeconomic levels of clients who come to us. A lot of them are below the high-end treatment cost. So we look at cost. And then we are saying that our guidelines, the basis or the base or the foundation of our guidelines is WHO. However, we tailor it to suit the country. And then it's regularly updated. I think there's an update issue. That's why some prescribers are going ahead to use the new ones on the WHO page instead of the ones we have. And then it gives you clinical management algorithm. So, example, typhoid, step A, B, C, D is what you're supposed to follow. And everyone treating typhoid should follow this algorithm. So it gives us, some of them are diagrams, some of them are steps or protocols to follow so that we can treat the patients who come to us. So we are saying that guidelines are a bridge between evidence and bedside, meaning that the guideline gives you concrete data. It gives you information and it tells you that if you do step A, B, C, and D, you are going to get results E, F, G, and H. And it's scientifically proven that it works. The bedside, if we use the bedside, the people who use their experiences, their 1966, 1666 experiences, and then we cannot limit that to healthcare providers. So it is between, sometimes you might see the algorithm, and this is what's supposed to be. But like our sister said, she tried, guys, like what she was using initially was not working. So it helps us to bridge the gap. Okay. I think I'll go on. Okay, so at this point, I raise my case. Please, do you have any questions, any contribution, or any concerns?
Thank you very much for the presentation. So, for me, it's my take home. So, my take home is what my brother said, that once there are updated international guidelines in the system, I think the DTC can take it up, and then we all agree, appraise the evidence before us, and then agree to adapt and then develop protocols from it. So thank you very much.
Thank you. So we are continuing with our session. At this point, we are going to talk about the institutionalization of DTC and then antimicrobial stewardship programs. And the aim is to build a sustainable antimicrobial stewardship strategy within the GAP-AMR. Okay, so this is more like a that's the aim of the institutionalization of DTC in these programs. This session is to strengthen the DTC and AMS capacity building for all facilities in Ghana Health Service and the Ministry of Health. We're going to cover what stewardship is, what antimicrobial stewardship is, strategic objectives, 4 of the GAP-AMR, that's access, use and disposal, and the components of the AMS, composition of the AMS team. What is stewardship? Anyone? Stewardship. Who is a steward? Anyone? A steward. Who is it? Anyone? So she says that someone mandated to oversee an aspect of any situation or anything. Okay, thank you. So by saying antimicrobial stewardship is a coherent set of actions that promotes responsible use of antimicrobials to preserve their effectiveness. Responsible use, underline, preserve effectiveness. And it's not about restricting access to patients who need treatment, but it's about ensuring that every antimicrobial decision is the right drug, the right dose, the right route, and then the right duration for the right patient. So we're not preventing the stewards, AMS is not a steward preventing us from prescribing antimicrobials. But I want to do it responsibly, safe, for the right person, and the right length of time. And we are saying that it ensures every antimicrobial decision, we already mentioned the right drug, dose, route, and duration, and it does not restrict access for the patients who need the treatment, and it operates through structured programs, so not ad hoc. AMS team, our job is not, hey, I hear 20 patients were seen. This and this is what happened. This drug is not really working, or there's a resistance. I heard this somewhere. Oh, quickly, immediately, we come together, we have a meeting, or we handle that issue you have just said. It's systematic and it's regular, and there's a plan for the activities of the antimicrobial stewardship program undertaken by the DTC. So we set out to achieve the program to improve clinical outcomes so that when our clients come to us, we treat them and we get the desired results. Minimize resistance selection. Reduce unnecessary antibiotic exposure to slow the emergence and spread of resistant organisms, and to reduce avoidable costs and harm. Imagine graduating from ampicillin to, you said the most expensive is how much? The 8 million one.
The ceftaroline.
Can you imagine? So small problems. And then the patient is graduating from this 12 CDs treatment to 800 CDs treatment. So we are not going to increase the health cost of the treatment for the patients, and we are going to cause harm to the patient. And then we are avoiding adverse drug events and downstream costs of treating resistant infections. The principle to the program is stewardship. It is global, it's cross-sectoral ethic. It applies to any shared finite resource. It guides national policy, and there's no single owner or accountable team. At the facility level, it's a structured program owned by the designated AMS team and the DTC. Remember we said they don't work in isolation, they come together. Okay. And then we are saying that we operationalize stewardship via the audit, policy, and education. Audit is when we do our surveillance, and then the policy is following the guidelines, and then education is when we all have information on what to do to combat antimicrobial resistance. And then it reports measurable indicators to hospital leadership. So DTC, in your activities regarding AMS, you collect data, and then you present your data, analyze the data, you collect the data, analyze the data or the information, and then you present your findings to management, who can use it to make changes or help to improve patient care. So how does it operate today? We do audits and feedback. We get prior authorization when it comes to the watch category and then the reserve category of medications before we dispense them. And then we have guideline-based prescribing where we use our guidelines. And then our prescribers, so if you have all these things and our prescribers are not getting the information, no capacity building, no updates on the current trends, it will be difficult for them to follow. And they will continue doing the things they're not supposed to be doing, thereby stalling our attempt to halt the incidence of antimicrobial resistance. So capacity building is important, especially for our prescribers. So equitable access. Well, strategic objective 4 is to ensure equitable access, appropriate use, safe disposal of antimicrobials, diagnosis, and other health products across sectors. Equitable access, everyone should be able to have access to antimicrobials that are safe. And that brings us to the A, where is the least susceptible antimicrobials to resistance. That level, they are cheaper, they work, and they are not high grade, and they are not very expensive. And they are least susceptible to resistance. So that at every level of your healthcare provision, rich, poor, any category of people can have access to it. And then appropriate use, the right prescription per the indication or the disease condition. And then safe disposal. Pharmacy, how do we dispose of, okay, so on what occasion do we have to dispose of medications? Please.
When they expire, generally, that's when we dispose of them. But then there's a procedure, you just don't get up and expose. So, first of all, we inform the medical director, and then through him, FDA is informed, so they come and do their checks. We liaise with the Environmental Protection Agency people. They also come and do their checks. look at the quantum. They talk about, so they agree with FDA. They talk about the method of disposal, whether it's crash and burning, and then the site, exactly where they are going to do it, and then the cost involved. So it is not a one-time thing, and because it also involves a bit of money. We do that. We have a room where we quarantine all expired medications, and because of regular stock taking, active monitoring and all that, we don't do that quite often. So I would say maybe at least once in 2 or 3 years, then we get quite, an appreciable amount of drugs. Then we go through that process. So after the medications have been destroyed appropriately with FDA officials and all that, we are given a certificate of destruction, and then we keep it. So it is, every now and then, very good like that.
Thank you very much. Do you have brown pen line? And the IPC, we use the brown. Do you have some? What's the last one?
Well, it's been a while, but usually when they come around, peer review, when they come around, I always, tell them my mind, because we all know that we don't leave expired drugs on the shelves. So it is not a question of you coming to the main pharmacy and then looking at your bin. Where is your brown bin? Brown line, you are supposed to have expired. It is not like you are serving and then you realize that paracetamol has expired, then we drop it in the brown bin. It doesn't happen. The drugs move from the store to the various points. So there's written checking, there's monitoring in the pharmacy store. So no expired drug leaves the pharmacy store. And then we do active stock taking at the various points. So immediately we realize that, it's a month, we keep our eyes on. Once it expires, we take it off the shelf. So it's not, we don't have situation that is working with it and takes the box and realize, it's expired. Where is the bin? The brown line, and let me drop it inside. So usually when they come, we don't see it. We don't have it. There are times when we've had it, earlier, some years back, but usually we don't get it from the general stores. And when they come, we explain to them that we don't have cases of expired drugs on the shelf. We have a room where we quarantine expired drugs. So for the brown lining, honestly, it's been about 2 years since I saw one with my 2 eyes. It's not that common. But then we don't have things like that in other families.
Thank you very much. But there have been incidences where the drug is not expired, but you look at it, maybe for storage reasons, or there's a part that is not fit to be dispensed to the patient. So that's where you can use it. So it's quarantine everything. Okay. Thank you very much. I have another question. So have there been instances where you did your survey and then you realize that there's this class of antibiotics which are no longer useful or fit for purpose? So you need to take them off your shelves. So they will be in the category E, where they are totally not allowed to at a certain point. Are there instances like that?
So if you say fit for, isn't that they are
in relation to the bag?
Yes.
I'm talking about there's a broken part, the package is not right, doesn't look, so you cannot, out of good conscience, dispense. Then that's related to the bag.
Yes.
But I'm also curious about incidences where you have had the experience of antimicrobial treatment that have been moved from the what category, where they have a high propensity to antimicrobial resistance, and then they are the E where you cannot dispense them at all. Have you met, in your experience, have you met such an incident? Where there was a time they're like, all these drugs, it's not expired. But because of ABC, in relation to antimicrobial resistance, we have banned the use of these drugs. So if you have some in stock, then you need to dispose of it. Have you had any?
No, we haven't had anything like that. The only instances where we had to take something off the shelf where it's not expired is when there's a recall from FDA. But with what we are talking about, we haven't experienced anything like that where we have to take something off the shelf because, no. So far, no.
The scenario I'm expressing now is something you have to be Thank you very much. So, safe disposal, we've talked about it. Better access. Okay. So, we are saying that diagnosis and regulation underpin. Okay, so we look for them in many other ways. We are saying expanding access to quality diagnostics enables appropriate prescribing. So, we are saying that if the patient comes with symptom ABC, we need to do our labs before, because it will help us determine the specific antimicrobial to dispense. And it improves our prescriptions and the patient outcome. Okay, so regulatory strengthening. We are also saying that national frameworks must cover the full antimicrobial life cycle, in that in development, manufacturing, and distribution, use and disposal of our antimicrobials, we need to go through that regulatory strengthening. An example would be the FDA, and then it also curtails substandard products. A lot of these Indian, Chinese treatments in town.
Okay, so on the substandard products, I would just want to give a case scenario of what we've had. So here, as part of the DTC, we take pharmacovigilance very serious. We don't leave post-marketing surveillance only to the regulator. So I'm going to cite an example. Although it wasn't an antibiotic, last year we had a case of a series of patients, hypertensive patients, who were previously controlled, and then they started coming in with hypertensive urgencies at the OPDs. So because we had a system in place to track at least most of the ADRs that are coming through our hospital, at the OPD, we got quite a number of reports. And so it triggered an alert. And then we realized on investigation that the brand of nifedipine we had at the time had changed from the medical stores. And all those who had the hypertensive urgencies previously controlled were those who were switched to that brand. And so immediately we informed the FDA. We also, because the cases coming were a lot, like 30 and more, so we also, the head of pharmacy also informed the regional medical stores. They requested for the FDA ADR forms to be filled, and then they came to substitute the brand for us. So in fact, at the clinical side, they did a lot. They did the challenge to see if indeed it was the brand, and after changing the brand, their BP controls came down. And so the DTC has actually written a case series on it, which has been accepted for publication by the International Pharmaceutical Journal. Thank you.
On this note, then I believe that with the information we have, it looks like DTC is actually, DTC is doing a lot of work. Yeah. So antimicrobial stewardship will be easy, isn't it? Yes, we can do it. Thank you. So we've talked about it's curtails substandard products. Then the component is leadership commitment, very, very important. Leadership commitment, management, support. Management support, very, very. Without management, we can do all the rounds we want to, have all the meetings, and without management support, we cannot achieve anything. All right. So management is the fuel that will fire the team. And then accountability. Drug expertise, we have experts. Action and interventions in our plans, and our work plans and action plans. Drug reporting, surveillance, and then education capacity building. So under leadership commitment, we are expecting that leadership will formally appoint, recognize and appoint with terms of reference the team, give us allocated time for team members to do their work. So we have days specifically for the team members to do stewardship. And then we have a designated budget for activities, training and data systems. And then we have performance review at senior management level and DTC level, so that we have the opportunity to come and tell senior management what the activities we are carried out and the progress so far. We identify gaps, and the management will be able to help help us to solve the problems we have identified. Accountability, we have the need, terms of reference, we already mentioned, reporting of AMS indicators to hospital leadership, define consequences and escalation pathways for non-adherence. Then drug expertise, actions and interventions. And actions and interventions, we have prospective audit and feedback, prior authorization when it comes to drugs that need prior authorization for prescription. And then we have facility-specific protocols. We said that WHO is the foundation, but every country builds on the WHO foundation. And then when you come to the local setting, the hospital, you remember we mentioned the antibiogram, specific scenarios, specific treatment, specific disease conditions, specific to your location and the facility that you are running. So it helps you to have your own protocols, like we are going to do after this regarding the oxytocin. We'll be doing something like that. You tailor it to suit your facility. Thank you. Then we'll talk about IV to oral switch programs. Hey, in Ghana here, when you go to hospital and they don't give you now for drip in single swab, doctor or the Google spot. So it's not correct. Every time you go to this doctor, it's giving you tablets. The tablet doesn't work. That's the Ghanaian story. But we are saying that as much as possible, we want to do oral. It helps in IPC too because as much as possible, we want to reduce the invasive procedure like passing your cannula, giving set IPC infusions, or exposing us to microorganisms. So as much as possible, we want to have those programs online. So tracking and reporting, education. So the team is a physician or the champion, the AMS pharmacist, medical microbiologist at the lab, infection control nurse, data surveillance officer, and then the Dtc link or hospital administrator. The program needs these people, and then institutionalization of AMS means building a permanent structure. So it's not like once in a while, it's not like peer review. Wait, and then when it's near peer review, you see all the things appearing from out of nowhere, and then after peer review, you should need nothing. We are saying that once we institutionalize it, just the way we've done the DTC, it should be part of our DT system. And then stewardship, our strategic objectives, all these are ways to institutionalize and make it a permanent structure. Thank you. On this note, my session has come to an end. Any contribution, any question? Any contribution, any question? Thank you very much. Mr. MC.
Thank you very much. Please let's give a round of applause to Ms. Chautukansi. Personally, I've enjoyed this presentation day too. It's been very interactive. As I sat here, I was just wondering to myself, am I seeing properly? Did they copy from us or we copy from them? Because when you look at our presentation yesterday, everything that we've talked about since yesterday, pharmacovigilance, lab, AMS, everything is in there. And we're actually doing it. Usually when you don't work well, and then there's a day of reckoning, it's either you keep quiet, you don't talk, or you bow your head, and then just that's fidgeting. But you could see that all the members are here just out, they are all hands-on. Chinua Achebe said in his book, Things Fall Apart, he wrote about the lizard that fell from the tall Iroko tree. The lizard swore to itself that, if nobody will praise me, I'll praise myself. So my general hospital PTs, we are doing very much for ourselves. And the little wonder that other facilities send their teams to the general hospital to come and study us how to set up AMS teams, how we went about this, how we went about that. We are doing well. And I always say that we, Tema General Hospital, we set the pace and the others follow. Thank you very much. Next, we'll take a little break, right? So stretch a bit. We'll take a few minutes break, about 10 minutes break, and then we'll come back again and then we'll finish off the day. Thank you very much.
Hello, good afternoon. Welcome back. Thank you, Marwina, from yesterday and before. And then we'll run through surveillance. So from yesterday, we started antimicrobial surveillance from the lab, microbiology. So we'll run through shortly and see consumption also. So the relevance, we talk about glass, consumption, the ATCDD, the system, and also the rights activities. So why surveillance is essential? I think this is not new to Tamajama, I presume. I mean, also because we started AMS activities. We need reliable data to inform decisions going forward, to inform policies. To inform decisions and policies going forward. And the data must be as quality as possible. Yesterday, we mentioned the poor reporting in Africa, so that the estimates for the burden of AMR, globally, will not be accurate because there's poor reporting in Africa. So what we're going to look at over here is to standardize our data collection when it comes to whether it's diagnostic stewardship or consumption from pharmacy. We spoke about the policy from yesterday, that the first action plan, global action plan, had 5 objectives. Early this year, it was updated to the new one, that's a 10-year plan, with an inclusion of an extra objective. The objective 2 from both action plans covers this talking about, or 2 and 4, but 2 essentially capacity plans for years. Okay. So we'll focus a lot on glass. That's the global AMR surveillance system. We won't focus on infant animals. Yesterday we said that it doesn't concern. It concerns us, but we don't have the control over that aspect. None of us will be collecting data for food and agriculture or animal use when it came to surveillance. Also reiterating the One Health approach, where environment, animal and agriculture is involved in AMR, AMS. So the national surveillance systems, all the partners are encouraged, all the states, WHO, all the states are encouraged to have proper surveillance systems. I think for glass, about 150 of us enter data into glass. If I may ask, does Tamajano use WooNet, or do you report to glass in Tamajano?
We started using the WooNet this year.
This year, okay. Okay. So before some of these engagements, most people had surveillance data. However, we realized some discrepancies in the quality of the data. So right now, WooNet helps standardize the data for us. So it means that you are likely to build a proper, a more accurate antibiogram from next year.
Sure.
Because you'll be collecting data over a 12-year period. Okay, that's fine. So we'll just mention small things and continue because I don't find. And also, that's objective focuses on creating reliable diverse systems. Even now there's a conversation about including AI in some of these things to better record the data. Over the period, we've had challenges with the EMRs, the electronic medical records. We're on LIMS some time ago, from KIMS today, and then most people complain that data was lost when LIMS. The same problem here, okay. We have the same passports, So that's about this one. So that's the glass, routine data surveillance. That goes into the antimicrobial resistance data surveillance. And also for pharmacies, the consumption, antimicrobial consumption surveillance. The focus is usually where, so routine, every time we're reporting, right? And the focus is where sometimes you look at the emerging ear marks, we call it glass ear. Or so you focus on certain problems at a time. So if there was a funny surge in antimicrobial use or a sound resistance, the focus surveillance would have focused on that one. There's a studies and service that goes into things like the others like PPS, the global prevention. We'll see that also going forward. The aim of GLASS essentially is to provide a common standardized methodology for measuring and reporting consumption. So before then, now it was difficult to get, because the methods for data collection was different for everybody. It was difficult to speak to data in aggregation, like for all of us. And we can talk about data for maybe to but it's difficult to compare because the methods for collection, the metrics were different. But now what GLASS does was it standardizes everything for us. So we can speak to Africa, maybe at a regional level, we can speak to a country. So won't bother too much. The fact that we know that this surveillance system exists is enough for most of us because it is handled at the national level. So all of us, and it is set specific facilities that will collect this data to be input. Because a place where there is no microbiology capacity, for instance, it's difficult to do some of these things. Not to say that you can't do AMS programs at those levels. Classical example is at the Raka College. I mean, it won't matter for you, but the fact that you're involved, you get to see the problem outside. They don't have a microbe lab, microbe also, I think. So what they were doing was that they used a third party, like a third party to get the data. But the challenge in that regard also is that they're unable to have proper control of the data. Because you have the lab here, you have proper control. As of then, for them, some people will come and pick the collect result and samples, there were gaps. So we're going through their data sometime and there were some gaps in it, and the reason was that they didn't have full control. Fortunately at the Majema, you have better control. So the objectives are to integrate the package of tools supporting the collection. With LIMS, some of the challenges that the lab had was how to transfer data. I don't know if it was the same here, yes. So, similar problem. So this is supposed to be able to bridge that particular gap. Provide quantities and types of consumer antimicrobials. This feeds into planning. Right now, we're dealing with the framework contracts. And sometimes, very easily, our stop loss can come from poor projections. Aside the financial part of the problem, so if we have proper data, we're able to now project. That is for consumption at the pharmacy level. How much we need over a particular period, so that we don't have things like stop loss, so we don't affect the quality of service provided. So common methodology I mentioned before, generate reliable, comparable data. If the standard, it will be reproducible, it can be spoken to across, you can benchmark across regions, countries, and facility types, for instance. Then feed the WHO, especially with the data, so you can see like a picture of the bigger problem. Enable comparisons in animal and also agriculture. I spoke about farm and animals that won't talk about it much, but that helps us do that. We were talking about guidelines, and there was a mention that accessibility and affordability. What's the point of your guidelines or medications cannot be accessed in the region? So if you compare guidelines across maybe the UK, across Africa, UK, Europe, and America, aside the variability of resistance, where the microbes in that region are different, there's also difference in because they might have certain ones that we don't have. remember some rounds in the UK, they mentioned antibiotics that I knew that even though they were effective, we couldn't find it. If we could find it, we couldn't buy it. So if you can find it and you can't buy it, I mean, you can't use it, then our problem of AMR continues to plague us. So that helps us to now project the ones that are accessible. Because certainly, if you are designing treatment guidelines, aside your facility data, surveillance reports, you'll be using which medications you have on the shelves. I think yesterday we mentioned about the goal of AMS projects, aside the use that you want to have targeted treatment, not considering the challenge of using targeted treatment. Number one is how soon the labs can be ready. For instance, if you request for a culture, you will not get the results that day. I mean, currently globally, we don't do cultures immediately. Unfortunately, it can't be urgent. So it will take maybe 72 hours or 5, depends on the sample, whether it's a blood culture or whatever. But they are going to employ targeted treatment. I mean, that's what we're encouraging. That's what we're encouraging. I mean, there was a concern somewhere where they were. I'll enter some parts of the areas because there are things I wanted to say when you're having the first discussion I didn't say, but when we get there, I will address and some of those ones. So that, oh, sorry, I'm losing the thoughts because I'm mixing the things up. The essence of, the relevance of stewardship is that because we are able to now project the quantities and amounts, and then in building the policies, we are able to build proper policies. So, in the absence of targeted treatment, we're going to use guidelines, as I meant to say. We're going to use guidelines where we will not encourage guideline compliance, some of these things. So, it is relevant. You can't have proper stewardship without surveillance. You can't, I mean, there's no point in, just like we see in other QR projects, you can't measure what are you doing in the first place. You can't speak to how much your efforts, you can't speak to the quality of intervention. So, a similar situation is there. I mentioned that surveillance will be controlled by the second and fourth objectives of the action plan. The architecture, national level, regional level, and global level. I've mentioned essentially what some of these ones. Now to set it up, so set up the surveillance system right at the national level. They identify certain needs. I mentioned that the data collection won't be across everybody. We're not expecting every facility to help collect data. In a closed system would have been the best, but unfortunately it wouldn't be the issue. Also, we'll be plagued by problems on the ground and not from textbook. I mean, if you have an AMS committee, I'm sure you understand what it means to work with the resources. You have peculiar challenges that are different from in Kolebu or in Lekma or in the UHAS. When it comes to a lot of these things, hospitals that have universities attached do better. We'll see that going forward. So UHAS doing some nice work around these ones because they have, I mean, whole hospital, it has some nice work because they have UHAS very close to them. Tech Hospital has K University, where it makes it easy. But for most of us who are not in those spaces, we're either bored or tired from some of these ones. The data sources I mentioned, there are peculiar places, and then the collection and validation also have peculiar places. Then the plan is to have data that's to places you want to have proper. In research, you see the problems, and sometimes the data is so scattered that you can barely speak to, but then the hope is they want to. But that is funded, so that people find a way. I don't know how your AMS communities find it here. I mean, there are teams. Certainly, I don't know that you run on motivation. If you do, God bless you. To say, oh, my boss will say thank you and I'm fine, but in all projects, you cannot do without like a complete or escape. Sometimes when funding comes, to start is nice, but when funding dwindles, it becomes challenging. So we'll talk about the use. One of the most quality data we can find is antimicrobial use. That is data at patient level. How much was dispensed to the patient? But going forward, that becomes very cumbersome to collect because it means that the general record data at patient level for the year. Like my brings for the it becomes challenging. So we try to aggregate it, and then that goes into consumption. We'll see that going forward. The point is that the closest data you collect, the closest the data is to the patient gives you the highest quality. Because they are over, you have medications from donations, from stores, it moves around, they are overlap. So then the better it is to the patients. Because if we can quantify that in 2018, 2,000 capsules of amoxicillin was given to the patient, then we know that's the amount that was used. But if we're going to now capture how much was procured and move over, it becomes, we lose that quality in those transitions. So the consumption, that estimates the use from aggregated data sources. So there's imports, there's wholesalers, there's all those places. But globally, it is the easiest to collect. You miss out on indicators like maybe the sex of the patient, the diagnosis. That somewhat helps, in certain areas. But we're able to focus on this one when it comes to national level policy making or global or regional levels. Now we classify them in essentially two systems: the anatomical diagnostic classification, chemical classification, and the DDD. There's an appendix for these things, so we don't commit them to memory. And because we've done the PPS, I'm sure you've seen some of your consumption. When the data comes up, you see some of the classifications. Level 1 to 5, anatomical groups, pharmacological diagnostic subgroups, antibacterials, antifungals. So the codings are there in respectively. I won't dwell too much on it. Okay, so because it's AMS, our focus, the conversation, there was talk about oxytocin, and that is outside AMS. The focus is on only antimicrobials. That's the idea. So even when you have an AMS word around by you don't have AMS. So you see, you only focus on antibiotic use. That is not for the GKA or the PP, whatever it is. So our focus is on the G. So lots of our codings when it comes to these things will be around the G. We don't worry so much about the other ones, and the organs or systems and medications affect another one. So the DDD. So in the new action plan, there's a focus to quantify using that system, the Dtc Training system. That's what we're doing. Before even the OPD PPS, we're doing prescription audits. And it's the same for you also, where you have like an Excel sheet. We're doing a tally system similar to the RUM. So medication, diagnosis, frequency, and all to collect for prescription audits at the pharmacy. Now that there's the OPD PPS audit, it helps. But so before that, we're doing those ones. We're not using a lot of these ones. I don't do so much because there's a different plan to better engage. So because it's difficult to compare the number of medications used across facilities, some of these things come in. So the DDD, where it's an assumed metric anyway. So the assumed amounts of the assumed average amount of medication used on a patient in particular for the adult medications. That means that it speaks to a limitation. We can't use them for pediatrics. There's also a problem with the things like when there's some things like renal impairments where there are those adjustments. So it makes room for all those things. Also focus on only systemic drug use. So you see things like topical medications, just your orals, your parenteral, maybe rectal. That's where this one focuses on. So the total amount of medications used over the DDT, that's those ones are they are not constant, but they are assigned. They are assigned by the WHO. Assign those ones for. If consent could be 2 grams, for instance, 1.5 grams. So we're going to compare how much we have used to those ones. As a single matrix, they are not. You can't speak so much to them. But the other activities you can compare with that helps. Things like number of patient days things like inhabitants, this like bed, number of bed days and all those ones. So that's what the DID comes in. So usually that will be the DDD over 1,000 inhabitants per day. You're able to speak to those ones. So you get like things like 20 DDD, 30 DDD, and the like going forward. Okay, so the calculation. We won't dwell on that. I'm sure we'll have that conversation later. But then it can be at products level or substance level. I mean, products across brands, across different dosage forms. So amoxicillin can come as brands. It can come in. There's the oral. There's the those ones. So even in oral, there's capsules, there's syrup. So we're able to capture the data across sensitivities as well, as opposed to substance level, where we can just quantify and say how much amoxicillin. So that would have covered all those ones. Yeah. So that's essentially. So it's report, like I said, as a standalone, DDs alone, when you measure calorie, you can't say too much about it unless you use them against activities. And the DID is the most used one. The surveillance focuses not only on public sector but also private sector. The challenge is whether it's part of the facility's vision at private places. I mean, I've seen IMAN try to be involved in some of these projects from there. And we have public places. Very easily, something will come in there. We have to do some of these things. Don't do things like RMA or private places unless they want to. I mean, but yeah, so it covers those ones. I spoke about data at community level, pharmacies and all. But the focus for us will be at hospital level and not so much because we don't have so much control unless you are passionate enough to consider doing that. And that's a part of the program. But in essence, after everything, you have to abuse them because it speaks to the quality of the data. We can't be at a point during COVID where people are worried that the numbers that we're seeing there only from public places and private places we're not capturing there. So it means that it speaks to the quality. Either way, so we could be under-reporting because maybe some private people were not now putting that data. There's a similar situation over here actually. I spoke about the collection at different points. I mean, it speaks to the value chain of medicines. Procurement, supply levels, distribution, prescribing, dispensing, and patient use. The closest it is the collection is to the patient point, speaks to the quality. However, unless it's a dropped process, maybe directly observed, you can't speak to patient use because we would have dispensed that amount, but whether they used or not, we wouldn't know. But then, if you can capture to dispense, then it helps. But of course, that's the data points that it happens across, essentially. Data management, I think we'll just skip data management. So I mean, going forward beyond this, we're hoping that our country will have like a quality and multidisciplinary consumption team. I mean, to help these things that will help map out and map and validate data sources. Adopt the Dtc is the new conversation that we're having. So it becomes a pharmacy problem. I mean, they say there are serious of medications, so it's only fair to give them this response as part of that title. I spoke about the essence of surveillance and in what we couldn't do without. So right now, since you have Dtc and AMS, it looks like going forward, all of us are encouraged to have these reporting systems. I don't know how you do it now. I'm sure it's a foundation we'll do later, but that's the plan that we want to do. So thank you. I'm sure there will be no questions. So or other questions. But my idea is rather convince or confuse you. So I don't know where. Oh, okay. That's it.
So with your section that you talked about organizing, like what are they going to do then? What are the initiatives relating to it? You see in your slot, I saw parents and like, what are the initiatives? What are they going to do?
So I was highlighting the data points for the surveillance. So in the consumption, very easily able to tell us how much came into the facility and from your end. and how much goes out of the facility for use, usually in form of pharmacy. So the data you have to is considered in some of these analysis. So as at the procurement point, there was distribution, there was a prescription. So at all those, because we could see that, I want to use an example. It's not AMS, but well, it's use of antihypertensives. When it came to malaria, I don't know if you have that problem, where they see that your prescriptions don't match your dispensing. You have the similar problem here. For no malaria, anti-malaria, the malaria program, you need to compare prescriptions against and also lab. And you have to, so it is a challenge that, I mean, it always comes up. So you see, at the prescription, at the lab level, lab can say we had 10,000 positives, right? Then we'll go and see how many prescriptions for the 10,000 at pharmacy level. But there are always certain gaps inside there. That it might be peculiar to you, but I mean, all of us have certain problems where we're like, okay, so with dispense, they are saying that it's less. I don't know if you follow. So in essence, the quality of the data is where it was used at a dispensing level. Because if they said, if lab said they got 1,000, did the person go back to see the prescriber for the prescription? Did the prescriber write the prescription? Did the prescription not come to pharmacy for pharmacy to dispense? I don't think pharmacy will see a prescription and say, I want to dispense. Or if they were stock outs, so they won't record as dispense. So that's where they're just data points that we use to connect the data essentially. That's what I did. So there's not so much what we push into pharmacy to stress about.
So what will be our key indicators?
Say again.
What will be our key indicators?
Your key indicators to the data. All you if that should be done, all you'll be given is just how much of the medication you got. That came to the essential. I mean, answer your own question.
So I think when it was the DDD, I think you rushed over it. I don't know for whatever reason. I want you to go over the DDD. Thank you.
So that's a decision that came after other presentations. So the idea is that we're supposed to do that with you only, not with the other people. Because we want to do the PPS quickly. That's also the idea to do it with only you. But because it's multidisciplinary, we want to go everybody. Right.
I hope it's right. The
Yes.
consumption is more technical and a lot of calculations.
So it's with
we don't
the-
want to bore you so much. It's pharmacy focused. So we will tailor it to them later on.
So this shouldn't take so much time. This one. We won't even do PowerPoint presentation again on the GBPS. I'm sure we've seen the forms before, for those who do it. So the beauty about the PPS, the forms we'll get, I think it would be better if we start in groups. And every group should have a pharmacist. So however the groups are formed, they should have a pharmacist in the group.
Since they are already doing it, please, which people conduct the PPS? The AMS team. This is more like an AMS activity. We just want you to have a fair idea as a DTC of what they do, but we will not bore you so much into the nitty-gritties of the work. So that they still need to sit.
Okay, then I'm sorry. So we'll talk about it very quickly, and I hope that for all others who are not on the committee that undertakes the activity, will appreciate how much work goes into it. But it's a very cumbersome process, I must say. And also because the forms are updated periodically. What you have there is from last month. It's the new form from 2026 May. So the point prevalence survey is a quantitative service, it's a snapshot, and it speaks to the quality of prescribing at the facility. So because it's a snapshot, it is very difficult to see that that's what happens over time. But it gives you an idea. It's able to identify certain challenges, certain gaps, so that when you have a training workshop, you're able to address those gaps specifically. I mean, it helps if you find out that there's a poor documentation due to review or stop dates. I mean, you can focus the conversation there around some of those places. So let's talk about it briefly. We do it at both OPD and IP. You do at OPD also.
So far, it's IPD.
So far, it's IPD. Okay. So you haven't done OPD yet. We're going to see your OPD data going forward. So at both, what happens is that we record the data. We include patients who are active antimicrobials. So usually before 8 a.m. in the morning, they should be active antimicrobials. We exclude those who are in discharge. So if we went to the ward that are in discharge, we don't add them. I'm sure the same thing we do over there. Yeah, so that's what we'll do. So auditors go around. Usually you wanted to have a lab expert, the pharmacist, and the prescriber. Is it what you do or only pharmacy does it?
No. The ones that we did, we included the prescriber.
You included the FP, so that's all. And use the paper forms.
We use the
Paper forms before you do the data. I remember there were some people who thought, oh, I'm too primitive to say use paper forms. But when you do the entry, you get to understand. When you validate, so usually, although there's a very simple criteria, they go inside there and then after taking data, there are some discrepancies. That's the painful part. So you have to now come and remove. So if you don't have paper forms to now go and refer, then it becomes a challenge. So they go in, they do the. How many wards do you involve all the wards? All the wards for them. You do one ward in a day. I mean, you do.
They do it over 2 days usually. We divide all the wards into 2 days.
Okay. So you don't enter the same room 2 times. Yes. I mean that's the whole idea. So I mean it's being done essentially. The focus would have been around this. The OPD one, because you have it, I'll just go to the one review. So the OPD one, some of the challenges we are acknowledging, they do that acknowledging. We started that with them like a year or 2 ago. So they include us also. You see, they shouldn't interfere with what's happening. Otherwise, it affects the quality. It boils on a lot of documentation. So if they went inside and they asked the doctor why something wasn't corrected, it doesn't get a true picture. The baseline is not very. It's not nice usually. The baselines in most facilities have challenges. Aside technical errors from data collection, also at the facility level. Like I said, I remember one facility, the first time the condition was so poor, REM was seeing a difference from it. And then when we went on the ground, we were not documenting so many things. We keep a prescription open. I mean, the reasons the doctors give, it makes sense for the setting we are in. So they are treating a case on the ward and they want to prescribe, say, clindamycin injection. So IV clindamycin 300 QID open. Open is when they don't write the closing date. But at certain facilities, when you're talking about the AMS, there are interventions we make to the normal process. So at certain facilities, I can speak for like my specialty, you have to close the prescription. You don't need to open because then you record poor review dates because it wasn't closed. You didn't write 3 days, 2 days. The compensation is that, oh, the patient relatives leave. So if we supply for 1 day, they might not have that. May I keep saying that if you can write 21 days, fair. But close it. So it's a habit thing. This one speaks to prescribing habits. If it's not written, it means it's not done. So we'll score you at 0. So remember in the beginning, it's not a dissolution activities. There was that kickback. I don't know if it's similar with what you have here. Some people don't want to agree that about it, but that's what comes out. It's a web-based platform, so whatever you feed into it processes and it comes back. There was a time when at the facility we had issues. What I did an audit like over I think 4 months with not with the PPS, but there were similar indicators inside there. And you see that the problem is there. It's not that. Sometimes you go and there's a discrepancy between treatment sheets and then the notes. I don't know if it's a similar thing you have here. So this now comes to fix those things. For the OPD, I was saying, you go in, it's for 4 hours at least in a day. The same 8 a.m. to 4 a.m. It's a different form. You see it in the documents you sent. And then, well, initially, we were thinking that the auditor should be in the pharmacy so that when the prescription comes, they'll go through. But the problem is, you see things like on examination, the data we're collecting, whether there's a fever. I mean, you can have a look at it, you can nod and help me with it. I mean, whether there's a fever, and it has to be in the consulting room. The problem is that when you are in the consulting room, it affects prescribing. Because the moment the prescriber knows that AMS people are around, it changes. I'm speaking on some authority because we compared REM data per facility and the OPD PPS, and it was different. For people who were recording 70% in antibiotic use, they were recording a very low amount of antibiotic use are there. And it's very easy because someone is in the room. You see, I don't know how big the consulting rooms are, but that's a challenge that we try to work around. So your auditors are advised not to be involved in anything. You don't say, you just say hi and you listen on and tick as you are going. The form helps, so then you tick. When it comes to the antimicrobial prescription use, is similar to what's in the IBD. So we check what we call guideline compliance. I'm sure your data from the previous IBDs will show almost 90% in very public. It's the same. About 90% there, you see. It's all of us, all of us with the green passports, it's the same thing. So that might not be a proper reflection of what is happening because I said it's a snapshot. So for instance, if today, July 1, patient was reviewed and then cultures were requested, at the time of doing the survey, they will not capture the cultures because they will not have been done by then. So it will speak to practice and attitude because Lekama especially I can speak for. They will check that, they encourage that it's requested. Whether or not it's done is not for, whether or not the labs are done is not for you. I mean, the patient might not be able to afford it. For all those reasons, I mean, the patient will say, why do all those labs and come and buy medication? The painful one is that they do a lab and then there's nothing inside. Then they feel like it's wasted resources. It is not. We need that information to work. So that happens, for instance. So at the OPD front, also you see where the request was done for like a culture or even the full blood counts. But you will not wait for the report to come. Just capture what happens at the time. There will be follow-ups that will be included. Someone could have been coming from yesterday before the prescriber the day before, and the labs were done. So then you record those ones. So it's only those on active antibiotics. However, to measure prevalence, you will include those who are also not on antibiotics. So the forms are two over there. How you check prevalence in the IPD is that you record the number of beds, total number of beds. Then you record total number of patients who are admitted at the points before. So in experience, those who didn't do that, we're having 100% prevalence because it missed that particular factor. So for this one, you're going to record simple data from the people who are not on antibiotics. And then there's a special form for those who are on antibiotics. What I asked that they did for the other facilities who do it, Adaraka does it, Mankobi does it, Tema does it, Mankobi also does it, is that on the form for no antibiotics, record everybody there. So that the moment there's antibiotics in the treatment, you record that and cross it out. I don't know if you follow. When you start, I think you appreciate it. There are two forms you have. There are two patient forms you have. One records only for the people who are not on antibiotics. I'm saying that the easier way to do it. I'm sure you figure it out, and just because someone has done it, we can share that information. Is record everything, like everybody who comes on that no antibiotic form. The moment there's a need for antibiotics, pick the other form, and then you can cross out from the other one. So you don't count them 2 times. Because when you're inputting data, you include all those ones. There's no duplication. Because if you want to wait before you miss out on the data, right? So that's happening. And then when you put it, the data now comes off. It's about the OPD. Now, I'm only going to touch on the aware classification as all of us appreciate already. So we're done with the OPD DPS. I'm sure if that questions, we'll come back and we'll find a way to have that, just for everybody to understand how the thing is. So after you do this, it's going to record indicators like guideline compliance. It will show that medical, surgical, ICU, those are the activities. Whether the medical cases, prescribers are being compliant. How we know that compliance when they prescribe according to guidelines that we are assessed at the facility. I mean STG for one and any other guideline. It's difficult. There's been this back and forth in certain places where prescribers will prescribe what's only they understand. I mean like something they want and then they speak to who inexperienced it works. It's very difficult to convince farmers. Usually we'll be saying guidelines, it's a very public student. So that's captures it. Now the stop or review is another one that's to record. You've seen the indicators. So it's a similar thing also for the OPD. Then when it goes into consumption, like I spoke about, it focuses also on our classification. So what was your last access? 59. Oh, you are short by one for the you see the updated action plan. Okay, the updated action plan. The target is no longer 60%. It's now 70%. So it means that Tamajana has some more work to do to increase access use. I mean, globally, the idea is to use the targeted ones more than the watch and the reserve ones. Yesterday, we spoke a little about the reason that should be we're not getting any new antibiotics. We're trying to safeguard the old ones we have. And all of us agree that once there's a use, there's AMR, like rational or irrational. So the access ones are the ones that are in most guidelines. They are safe to use. They are the organisms are sensible to them means that they have activity over the organisms, but they have a low risk of resistance. So when you look at the Excel sheets, some switch sometimes. You know, like one isomizing can move from reserve to watch on to access. I mean, it's updated periodically. So the watch groups, they are also very they are also sensible to the organism. However, they have a higher risk of resistance. It's why they're the watch group. So you can the reserve ones are the ones that they're the large source drugs. I mentioned some the last time that we're leaving for things like drug-resistant TB. The newer generation of oxyfloxacin, fluoxacin, and all those other new ones, levofloxacin that we want to keep. And if there is use from it, becomes a challenge. So the target for the action plan is that 70% should be from the access group of antibiotics. And if you stick to guidelines well enough, you can make the 70%. You can try, because not many people do 70%. I think like mine are about 65%, 68%. Some also does about 6-something%. And the data I've seen from those facilities. So from 59, it means that there's more work to be done. So the more, if we're sticking to guidelines, it usually helps. Like if we're going to do, because those ones in the access group are the ones that are within the guidelines. Thank you. If there's any questions, I know I'll just take them. Is there any?
Please, are we confused?
Oh, we understand it so well. I know the latter is true because you're already doing it. So, thank you. We will move on to the next presentation. That will be our last presentation, and then we'll call it a day.
Good afternoon to us once again. So my name is Mary Eke, and I'm going to take us through ensuring access to appropriate antimicrobials and other health products. So we are talking about access of these antimicrobials that we have. Have we thought of having enough antimicrobials and how our consumption pattern changes, and also how when we don't have enough, it affects our consumption pattern? So let's say the pharmacy will say, we've received this antibiotic, that. We have to make sure the prescribers prescribe. We have to make sure we consume all. We have to make sure the patient take them home. So we now send bullets to the prescribers, telling them we've received this, we have this in stock, and prescribers must prescribe. And also when we don't have enough, how is it going to affect the consumption pattern, the prescribing pattern? So we are discussing ensuring access to appropriate antimicrobials and other health products. We will look at why access matters, the access framework, the dual imperative, quality and supply risks, 5 pillars for scaling access, and then diagnostics and vaccines. One will ask, why are we talking about vaccines here? So we will get there. So let's talk about access as a universal health coverage. You know, WHO has been monitoring countries on universal health coverages, and one of the key indicators are access to essential medicines. So the SDG target 3.8 commits countries to universal health coverages, and this looks at access to safe, effective, quality and affordable essential medicines, including vaccines. So now, when we talk about essential medicines, vaccines are part of essential medicines. We know in our facilities, when it comes to vaccines, the pharmacies are not part. The pharmacies are not even informed when they are going in for vaccines. Vaccines are reserved for the public health programs. But as DTC team, we should look at also monitoring and having oversight on the vaccines as well. Yes. So we talk about a core coverage indicator which looks at access to safe, effective, affordable medications, including vaccines, as a coverage indicator in the WHO track towards universal health coverage. We are also looking at the foundation of care, whereby most of our public health interventions and also our antimicrobial controls are all indicators that are being tracked towards a specific country's universal health coverage. There is a survey by WHO that is informing us that 1/3 of the whole world's population lack access to essential medicines. The whole world, the population, 1/3 of us
lack access to essential medicines. And about 50% of we, the low and middle income countries, lack access to essential medicines. When we take the whole world, it's 1/3. But when it comes to Africa, Sub-Saharan Africa, 50% of us do not have access to essential medicines. And because of this, sometimes our procurement systems also prevents us from accessing essential medicines. We all know the bureaucracies in our procurement. By the time we get the stocks, we've gotten to stock out, we've run out because procurement delays, and that is going to affect our access to essential medicine. And when it happens like that, sometimes we procure the medications twice the prices. They become more expensive. And when they become more expensive, it means it will affect affordability. And when our clients are unable to afford, it means access is being denied. So we have to look at our procurement systems in our facilities as a DTC team as well. We say about 15 to 25% of our medications to get expired before they get to our clients. We usually go for the stocks from the medical stores. Sometimes, right from the medical stores, the expiry dates are so close. We bring it to our facilities and in no time they are expired. This means we have to initiate procurement processes. And by the time we finish the procurement process, the stocks are expired and we don't have stocks. And that also affects accessibility of essential medicines. Why this is urgent for Ghana? Why is accessibility so urgent? Why must we talk about it? As a DTC team, why must we be so keen about access of essential medicines, including antibiotics and then vaccines? There was this point prevalence survey of some facilities in Ghana, and we realized that about 55% of our inpatients depend on at least antibiotics. So in this case, if we don't have access, and here is the case, about 55% of our inpatients are supposed to be given antibiotics. This means we will have to take a critical look at our accessibility. And out of this antibiotics that we put the patient on, about 70% of them are resistant to the microbes that are usually found in the facilities. Over 70% of them are resistant. Global death so far, due to bacterial resistance, antimicrobial resistance, is about 1.4 million individuals dying because of antimicrobial resistance. % of our antibiotics, when it comes to the WHO aware classification, we are supposed to be within the 60%, but we realize that we usually bypass it, and about 70% of that are being used in our facilities. And that also affects antimicrobial resistance in our facilities. So medicines must be appropriate, they must be available, and they must be affordable. So we have the 3 A's. So when we talk about appropriateness of our essential medicines, it means we have to be very vigilant when we are selecting our essential medicines. This tells us that the DTC, if we are selecting our essential medicines, is it guided by evidence? What evidence are we using to select those particular essential medicines that we find on our essential medicine lists? Is it also guided by diagnosis? And is it also guided by actual therapeutic needs? So the DTCs must bear in mind that, yes, we have to have our own formulary and our own essential medicine lists. But how are we selecting those medications that are on the list? Now we talk about availability. Are the medications available where they are supposed to be when they are needed? Is our supply chain system, is it that resilient to support availability of stocks in our facilities? Let's talk about affordability. Is the DTC team selecting affordable and efficacious essential medicines for our use in our various facilities? So these are the questions we have to be asking ourselves when thinking about access of essential medicines in our facilities. So we come to the dual imperative, that access and appropriate use of antimicrobials or essential medicines. When we have insufficient access to essential medicines or antimicrobial resistance, we all know what the consequences can be. Either our infections won't be treated very well, or the infections will continue to spread because we don't have enough stocks of the right essential medicines or antibiotics we are supposed to have in the facility. The patients tend to go and procure substandard or counterfeit drugs because they came to the facility, the medications were not available. Prescriptions have been given them, so they go out there, they see any drugstore, chemical shop, they think they are all pharmacies, they go in there, some even meet them in the market and they buy from them. So availability of our medicines in the facility is very key. Insufficient access to can lead to partial and inadequate treatments for selected medications, and that also leads to antimicrobial resistance. Diagnostic gaps. We know that some of our facilities might not have the laboratory reagents enough to be giving us the diagnosis or the antimicrobial tests before the prescribers prescribe. So in this case, we will say that it's not our fault because we don't have the necessary equipment in the labs to do those antimicrobial sensitivity tests. So therefore, why must we worry ourselves? What will the DTC do about this? are we going to advocate for the provision of those diagnostic devices for the labs to be able to carry out the antimicrobial sensitivity tests before antibiotics are prescribed? And when we have overstocks, are we monitoring how the stocks are being moved so that we don't end up overusing and misusing the medications or the antibiotics because we have a lot in stock? And overuse too will lead to antimicrobial resistance, just as insufficient access also will lead to antimicrobial resistance. So the DTC team should always make sure that we have the right quantity of medication at every point in time so that we don't have insufficient access and we don't also have too many to result in overuse or misuse. We now talk about the 3 pillars of Objective 4 of WHO, universal healthcare monitoring or tracking. So we talk about equitable access of essential medicines. We all know that we have to ensure equitable access at all levels of our facilities. At the facility level, we have to ensure equitable access of every type of essential medicines we intend to prescribe for our clients. We have to talk about the prices as well. Are we making sure that most of our medications are on the NHIS list so that the clients that do not have enough out-of-pocket money to pay, they also have access? Are we trying to stop only the most expensive ones because we have to, make some funding available for the facility because facility is also somehow have to survive? So we are not thinking about equitable access. We are thinking about how products are supposed to, be very effective. So we are thinking of stocking only the branded products, but we have equally generic products that are on the insurance that are also very effective to make sure that we have equitable access. When we talk about appropriate use, are we thinking about the WHO aware guidelines or classification to make sure that the antibiotics that are supposed to be reserved are reserved? The antibiotics that are supposed to be watched, are we watching them so that they all don't grow resistant to our antibiotics that we have in stock? Let's talk about disposal. The DTC team, are we making sure our products that are expired are disposed safely, or we are just leaving them in the care of orderlies to just monitor them for us when we don't have use for them again? We just don't care about them. How is the DTC team making sure that the environment too comes to play when we talk about safe disposal? So we know that our DTC team have a lot of work to do when it comes to safe disposal of our expired medication. So let's talk about what drives poor access. what drives poor access. The first one is poor selection. It's our selection of medications on our essential medicine list based on current evidence or data. Surveillance. We spoke about surveillance. Have we taken the pain to do some surveillance in our facility? The particular microbes we deal with and have the data and evidence that guide our selection of antibiotics or essential medicines in the facility. The DTC team, how well are we going to improve on that going forward? Let's talk about our supply chain. How is our supply chain? Isn't that resilient? Our professionals, the supply chain professionals, how well are we going to build their capacity as a DTC team so they forecast and quantify very well for us so that we make sure we have stocks all the time. We don't run out of stocks before we are now running to the medical stores to go and get stocks. When we get there and the medical stores too doesn't have the stock, we are now coming to initiate the procurement process. This affects availability and access at the facility level. So as a DTC team members, we shouldn't leave out the supply chain personnel. We have to see to building their capacity all the time for them to know that they are also a key player when it comes to availability of stocks in our facilities. Let's talk about our procurement processes. The bureaucracy in the procurement processes, they affect stock availability in our facilities. So as a DTC team, I know procurement is part of the DTC team. So how are we going to support the procurement, the team, to know that when it comes to procurement of medications, the bureaucracies should be, monitored so that it doesn't affect stock availability in our facilities. Let's talk quality and supply risks. Counterfeit and substandard medicines. As DTC team members, how are we monitoring our stocks to identify substandard and counterfeit medications? Studies are showing that in developing countries, about 10 to 20% of our essential medicines fail quality control. 10 to 20% of them is huge. What are we doing, DTC members, about this? When we have this at the back of our minds, that 10 to 20% of the essential medicines fail quality control tests. So this tells us that whenever we receive us, open our eyes to identify these substandard medicines and also the counterfeit ones. WHO also did a study and realized that out of these 10 to 20% that fail the quality control test, 28% of them are antibiotics. So it means that the counterfeit and substandard quality of medications, 28% of them are antibiotics. Why antibiotics? So this should tell us that we should be vigilant when we receive stocks of our antibiotics and look out for the substandard ones and then the counterfeit ones. Expired medicines, a costly failure. Expired medicines. Why should we even sit down for our medicines to expire in the first place? As a DTC team who have some stocks of medicines expired, have we taken the time to look at what actually happened in the supply chain? Where did it come from? And how are we going to improve to prevent any stocks from expiring, because it gets more expensive when we are destroying them. Though they are expired, we didn't get any value out of it. At the end of the day, we spend money to destroy them in addition, which affects the little resources the facility have. It is said that 15 to 25% of medications that are procured expire before they get to the clients. Why must it be so? Why should we over-procure to the extent that they get expired before they get to the clients? And in sub-Saharan Africa, we lose over $12 billion to expired pharmaceuticals. Over $12 billion. This money could have been used in buying us more stocks to treat our patients, but we are losing it to expiries, which is very unfortunate. So let's talk about scaling up access and the 5 pillars for scaling up access. So if we want to improve on our access to essential medicines, what are the pillars we need to consider? We first of all have to think about careful selection of the medications. If we select them carefully, backed by data, I know we will improve on our access. Formulary optimization. If we optimize the use of the formulary, we know we will improve or scale up our access. Forecasting, quantification, and supply planning. If we do proper forecasting backed by data, we will definitely improve or scale up our access. Pooled procurement will also help us scale up our access, and then workforce capacity building will also help us improve on our access. So we first of all pick the careful selection of medications. As DTC team, I know definitely well that your selection will be backed by treatment guidelines, policies, and evidence-based with surveillance data. We should keep it up, and that will improve access of essential medicines in our facilities. Let's also think about prescribing guidelines. If we have developed some prescribing guidelines on our own, in our own facility, it will guide our selection of medications, and that will improve access of medicines. Let's talk about the formularies. The formularies, I know definitely well that we have one in our facility, but are they being updated? Are we updating it based on evidence, or we just have it and we just go by it all the time, year on year. It is the same formulary we are using. We are not updating it. We are not improving it. Are we also thinking about post-market surveillance, pharmacovigilance, intelligence gathering to inform our formulary that we have in our facility level? And are we also watching the antibiotics on the formulary? Are we applying the aware classification in that formulary? Let's talk about forecasting, quantification, and supply planning. Is our quantification based on consumption data, or we just use our own intuitions in quantifying the medications we need? We are ready to go to the medical stores. We pick, among the and the 2 cartons in AUC. Until you're ready 2 cartons. Is it based on consumption data? As a DTC team, we must improve on our quantification. Forecasting, especially the antimicrobials. How are we forecasting them? Have we thought about relationship between the forecasting and consumption pattern and antimicrobial stewardship interventions? If we are applying antimicrobial stewardship interventions very well, our consumption of antimicrobials should be reducing. Month on month, year on year, it should be reducing. It shouldn't be increasing if we really implement the interventions of our antimicrobial stewardship. So every year on year, when we do our quantification and forecasting, we should observe a decrease in trend of the consumption of the antimicrobials, especially in our facilities. Are we also thinking about getting a very robust logistics management information systems to guide us, to help us in our quantification and forecasting? We know we don't really have money in the facility, but are we thinking about using digital instruments to guide us in our forecasting and quantification? If we should do it manually, it becomes difficult. But can we think of getting a very good logistic management information tools that will help us, guide us? Now AI tool is there to help us, give us quantification and forecasting data that inform effective decision making when it comes to quantification. Pooled procurement. I know most of the facilities are doing this framework contracting thing, which is very good. That will also scale up or improve access when we use this pooled procurement. Let's talk about workforce capacity development. How are we developing the capacity of the procurement team and then the logistics team as well? How are they helping us when it comes to quantification and procurement? Do they really know about the reorder levels, the maximum, the minimum levels? Do they really know about the months of stock? If they have some stocks, do they even know how long those stocks are going to last them? Are we building their capacity on that? We know we are DTC members and we talk about the clinical things. Are we looking at that side as well to build the capacity of the procurement and the logistics team to be able to help us quantify and procure our medication for us on time. Sure. So we talk about beyond the medicines and how it all fits together. We are talking about the diagnostics. How are we thinking of equipping the labs, getting the diagnostic devices readily available to guide our prescriptions so that we don't overuse the antibiotics to end in antimicrobial resistance. We are talking about vaccines. Why vaccines? Are we thinking about using vaccines to prevent a lot of these infections? When we talk about the use of vaccines, are we thinking about improving and educating the public health division to encourage a lot of vaccination? An example is the BCG. The BCG vaccine will protect these babies from this tuberculosis. And we know in tuberculosis treatment, we use a lot of antibiotics. So are we thinking about preventing the incidence of tuberculosis so that we don't end up treating patients with a lot of antibiotics? Other vaccines to protect us from even influenza. We know it's cold. They want to go in for antibiotics. Meanwhile, cold is not even caused by bacteria, but they have this perception that without antibiotics, the cold or cough is not going to go away. Are we thinking of educating the public on getting these flu vaccines so they don't end up getting the flu and end up using a lot of antibiotics to lead to antimicrobial resistance? So as a DTC team, we have to look at the public health area very well. How are the vaccines being stored? Are they breaking the cold chain? Are the vaccines being effective? Are we monitoring that area as well? Some of even our healthcare workers don't even believe in vaccines. So once the mother says, I don't want any vaccine for my child, they also say, okay, they relax. Instead of educating the mother the importance of the vaccine, to convince the mother to get the child vaccinated, even the mother herself needs some vaccines at some point. This will protect them from contracting a lot of this infection, leading to the use of antibiotics that end up in antimicrobial resistance. So DTC team, whenever we are talking about the medications, we should talk about the vaccines as well. We should monitor the vaccines as well, because it is a good way of protecting the clients from contracting a lot of infection. What are some of the key takeaways we've learned today? Securing access is everyone's responsibility. Now we know that to have access to essential medicines and vaccines is all of us our responsibility. Access failure drives resistance. If I come to the pharmacy and I don't get the medication and the prescription is giving me, I'll end up buying it anyway. And I may not be served with a very good product, maybe a substandard product that will lead to antimicrobial resistance at the end of the day. We talk about the 3 A's. That's appropriateness, availability, and affordability. Are we selecting the appropriate medications on our formularies in our facilities? Are we making sure the medications are available at every point in time? And are we making sure we are stocking affordable, essential medicines, whereby the medicines too, most of them are found on the insurance list to increase access? Quality assurance cannot be an afterthought. Are we opening our eyes to look at the substandard medications, the counterfeit medications, and are we monitoring our expiries in the pharmacies to avoid us losing money to also destroy the expired products? People are the foundation. Are we looking at building the capacity of our staff so that we will improve access of all essential medicines and vaccines in our facilities? Thank you very much, ladies and gentlemen. Any questions from me?
Thank you very much, thank you for the presentation. Mine touches on the issue of drug expiry. I want to say that we have a challenge, not only in Tamajana Hospital, but facilities that take their allocation from medical stores. The recent extraction that we did, when we looked at it, most of the medications were coming from medical stores. And usually there's a push system. You don't request for it, but when the delivery van comes, Tamajana Hospital, you've been invoiced, and then you've been given antimalarials. Recently, within the last 1 month, we got some. So I was trying to push it away from the top because we're giving some a few months ago, which we haven't even exhausted. We are struggling with it. And you know, with malaria too, you test before you treat. So you can't force it down somebody's throat. So we have the consignments that we are grappling with. And then I'm alerted that we are giving another allocation. I said, no, I don't want. And I said, no, you can't say I don't want an allocation. It's all the facilities, you have to take it. And then it comes and then it adds up to what we have. And then patients come, they are treated as negative. You can't force it down their throat. The dates are very close. November. Then it sits and then it expires on you. That is money. Other times too, it comes, it's close dated. You have program medications, HIV, very close dated. It comes and then it's about 1 month to expiry, huge quantity, sometimes allocation, most of the times allocation. There's nothing you can do about it, and then you watch and then it expires on you. The interesting thing is that sometimes you think that, oh, let me just, talk to sister facilities around and see if we can swap. Unfortunately, we take our stock from the same point. So they tell you that, oh, we're also striving, we're even thinking of bringing you some because Tamajana, you are big. And then we tell them that we have. So these are things that sometimes really, for the ones that we procure from outside, because of the systems that we have put in place, we have a verification team. So it's not me sitting in my office and then a supplier comes from NS Chemist. Then I say, oh, okay, or stores taking it. There's a verification team, there's audit on it, there's a stores person, there's a pharmacist. I know you come into the picture. So there's a team that is there. If we don't get a complete team, because auditor comes and he looks at it, oh, he might think that probably it's the same medication. But then the pharmacist, we need a pharmacist there, we need a stores person there. So they come as a team and then they verify. Recently an award was given for effervescent vitamin C 1 gram. I was in the office when the stores pharmacist walked in and said, Auntie Vivian, something is happening, I think that we have to reject this. We went and the award stated that effervescent vitamin C 1 gram. When we looked at what the supplier had brought, he had brought sachets of soluble, it's a syrup type, some funny sachet, 1,000. So I asked him that, boss, You're having a copy of the award letter. Is it effervescent? Oh, what's if I said, is it effervescent? They said no. Then I said, take it out of the store. We are not accepting it. So because of the systems that we have put in place, if the pharmacist alone had said, oh, okay, let's take it into the store, it would have been a bed, you call the supplier and he will not come. But they come as a team, audit comes to verify. So that he wouldn't take my word that, oh, when we took it, Auntie said, we're left 2 years to expire. It's stated in their award letter. Anything that is less than 18 months to expiry, we don't take. If we don't have at all, and then we completely run out, then we might say that, oh, okay, because it's 6 months to expiry, we are reducing the quantity. So go change your invoice, change your way bill. Instead of 1,000, give us 200. At least we are sure that that one will go. So for drugs that we procure through our system internally, these are the rigid checks that are in place. So we don't often have them expiring on us. The ones that expire are largely from outside. That is what I want to say. And then touching on counterfeit medicines. And I'll say that for most of the time, with your naked eye, it's a bit difficult to tell. There was an instance where we all know Coartem. There was counterfeit Coartem in the system. And when you place the original and the counterfeit side by side, honestly, you can't tell. You can't tell just by looking at it. There's no difference. Occasionally, some packaging may look a bit funny. Then you might suspect. But largely, what we depend on here that keeps us going is active pharmacovigilance. That is where we don't sit and then wait for reports, but wherever we go in interactions with the patients, as you are dispensing medications and you strike conversations with them, you give them medication, they'll give it back to women, that's what led us to picking a lot of reports on the Philippines, which came from medical stores. Eventually the brand was changed for us, and then the complaints just vanished like that. So we feel that a lot of ADR folks on that the Philippines forwarded to FDA waiting for feedback. In much the same way, there was a case of tranexamic acid and then heavy mercury that had the same packaging. The same, orange and white, the same. So then again, there was a lot of pressure from theater. And you know that for the systems that are laid down, I cannot bypass the system and say that I'm going for Aspen, heavy mercury, whilst regional medical stores has mercury. I have to get non-availability certificate approval that we all know that is not available from medical stores. Then when we are procuring at evaluation, we'll be able to say that this is what theater wants. But here's the case where it's available at medical stores. And then it comes and they realize that it's the same packaging with tranexamic acid. So anything can happen. So again, I had to contact the regional store, medical stores manager, and even the chief pharmacist. And luckily for us, there was another branch of Mackay by M&G. So we had to retain all that, and then we took the purple colored Mackay from medical stores. That helped us to differentiate a bit. Because no matter how vigilant you are, we are human beings. We get tired, we work, something might happen. So some of these things really, they are a bit beyond us. And when we see them, we make the necessary reports and then we try and push to the top until we get feedback. So that's what I'd like to say. Thank you very much.
Thank you very much, Vivian, on that. I think with the expiries from the medical stores, I think, Dr. Nai, we have to speak to chief pharmacist about it. Yes. Because it looks like when it comes to the internally procured medication, they don't have any issue about expiries. All their expiries are linked to the medical stores. So we will engage and give you feedback on that. Thanks so much. Fortunately, the chief pharmacist who is part of this team that is going out with this activity. Yes, so we will communicate this to him, and then something can be done about this medical stores expiries. Thank you very much for the good work
you are doing.
Talking about the delays in procurement, sometimes it doesn't happen that we want to sit there and delay due to certain circumstances, like cross mature, how the rains are coming up, and you have rains and having your own colleagues come and do the work for you. They have to stand by. In that aspect of it, that looking at your certification, without you don't get a certification from the region before we buy. We don't just go and buy because we want to buy. We take certification, get our approvals before we go and buy. And it goes through all the processes, and that comes the delay. So we don't just want to delay. Sometimes it's due to rain, sometimes it's due to so many things. Because of people not coming to work. Sometimes it's our own personal reasons. When approvals is not given, how do I buy? So the delay is, I don't know where I sit from. Thank you.
And also to,
Thank you.
and also to add a bit to what Rosina said, sometimes they go through their processes very seamlessly. An award is issued, but then it's from the supplier end. Oh, once at a time we go say, we just run out, oh, we're expecting some next week. Next week, you reach out again and say, oh, give us 2 more days. By the time you realize, when you think of rolling it over to the next person, the month is gone, and you've stopped out. So sometimes it's not always that the bottleneck is from the procurement side. Sometimes they do it, but then it's from the supplier end. They keep doing like this, like that. Oh, next week, oh, we are expecting it. Then we tell them, oh, if you are not ready, just let us have a letter so that we roll it over to the next one. Oh, just give us a week more. We are sure about it. We are kind of it. And all these things go to affect our stocks.
Thank you very much. We are picking a lot of information. We hope to work with the chief pharmacist and also the director of Pharmaceutical Services Directorate, and we know we will get very good feedbacks for you on that. Thank you very much. Any other question? Any other question for me?
No questions for me.
Let's give it nice for very well delivered, and still through the questions to very safely. Thank you. Thank you all for coming. We are rounding up. Our last bit is to, before we started yesterday, we did a pre-test, so we want to conclude with the post-test. It's very brief and instant results, as you are aware. So just 10 minutes, please scan the QR code and do the test for us, and then we'll be proceeding. And the posters, we all saw our results instantly, right?
Please let's come closer so that I have a closing prayer and take some pictures and then we can call it a day.
Please tell them that we are closing, but we want you to come and join us so that we take a picture. Okay, thank you. I sent it to
No, but can I get a scan so I can do the score?
Okay.
So, but you have my number. Yes. I put it.
Please, medical director will join us. We'll have a closing prayer, then we'll take a few pictures. So let's just complete our evaluation forms, then we'll be done. Please let's come closer. I have our closing prayer. 2 seconds. After which we'll take the pictures outside. These pictures will be dark. Yes, so we're sharing the grace. May the grace of our Lord Jesus Christ, the love of God, and the fellowship of the Holy Spirit be with us now and forevermore. Amen. Please,